So I suppose this is going to be in English. It's my privilege to be here and moderating among friends and experienced colleagues. We don't always agree on everything, but we do share a very strong effort to do the best for our patients. Dr. Gravanis is a very experienced plastic surgeon, director of plastic surgery unit at, come again? Protexeni. So it's not Dr. Gravanis, sorry for that. We'll have the pleasure to hear from Dr. Barbara Cagli, who is a reconstructive plastic surgeon at the surgery breast unit of Campus Biomedico University in Rome. And we're going to be hearing from her on her experience with the new era of aesthetic breast reconstruction after mastectomy, myth or reality. Dr. Cagli.
Okay, thank you. Thank you very much for the kind invitation. It's a pleasure for me to be here. Do you hear me properly? Can I start?
Yes, please.
Okay, thank you. So it's a great honor for me. Thank you for the kind invitation. So let's talk about the new era of aesthetic breast reconstruction. What does it mean? It means that everything is changed about breast reconstruction because fortunately, today we talk about ulcer mastectomy only in selected cases, maybe only for sarcoma or very rare aggressive cancer. So routinely, we talk about today in conservative mastectomy, and especially after the incredible improvement of genetic consultation, we still have a lot of prophylactic mastectomy, which is maybe a little bit dangerous in my practice because I spent so many times talking about doing consultation with prophylactic patients because there is maybe a little bit the feeling they're going to perform an aesthetic procedure. Instead, it's very important to clear them that they are going to perform a breast reconstruction, which is a totally different concept. So in the same way, also reconstruction is changed because, for example, when I was a resident, they teach me to cover as much I can every kind of implant or expander because they told me that it was dangerous to put in the subcutaneous space. But nowadays, exactly as it happens for breast aug, because we spend a lot of time doing a lot of dual plane, and now we are shortly and slowly coming back to pre-pack. Also in breast reconstruction, we are going back to pre-pack reconstruction and we are performing more and more. I have to remember you one thing that the pre-pack was the first kind of reconstruction described in 1978, but for sure the pre-pack that we perform now is completely changed. And this is because actually, if an oncologic surgeon makes a good mastectomy, for sure, 100% we can perform better breast reconstruction. And this is, I think, the key point of every kind of reconstruction. So thinking, I want to show you my way of thinking. What does it mean? It means that, I don't know if you know this kind of movement. Of course, I totally respect because breast reconstruction is not mandatory, but is a choice that women can have to do. It's not mandatory, but this is the Milano Fashion Week. So sometimes we receive from United States not the best idea, let me say, because I am a woman. I think it's not the best way to be proud, you see, of a radiated breast or to go with a chest wall, because I think that it's very important to give the opportunity to do a breast reconstruction. So 100% my way of thinking going in this opposite way to the going flat movement. And I started some years ago a sort of mind revolution. What does it mean? It means that I start taking care, not considering the same procedure, breast aug and breast rec, but thinking about planning my breast reconstruction exactly as I plan my breast augmentation. And what does it mean? It means that the preoperative assessment is the key for the success of reconstruction. You have to look at all the difference between breasts. You have to make a lot of measurements. And let me say that it's not a fight between to stage or direct to implant, because in our country, I don't know in yours, but patient, when I explain them that maybe they need to put an expander, they look at me like if it was a tragedy, because now it's the concept is that only pre-pack is a good reconstruction. This is not true, because The reality is that depends on patient selection based on native breast anatomy. This is another key point to assess, I think. So it's important to do measurement, to make a preoperative assessment. This is a normal draw that I do every time. There is not a big difference with breast augmentation. So I do calculation on everything. I try to figure out the difference between the two breasts. And so the idea is that we have to customize the technique for each patient. There is not one only technique which works, but it depends on breast anatomy. And you see, when you choose the implant or you choose the expander, you always take the look of the appearance of the shape, and you try to figure out, this is, for example, our monolateral expander, and you try to choose the best one who replicate better the healthy breast. But again, it's a question of measurements, because, for example, in this case, I find out that was the best solution was to have a height expander for this lady. And you see, this is a submuscular expander. You can say that it's an old-fashioned reconstruction. This is not true. This is the good reconstruction for this patient who asked me also to enhance her volume. And so what else about inframammary fold incision? My colleagues, they teach me so many things. And for sure, when I do perform breast augmentation, I do really precise calculation. But the same concept I applied in breast reconstruction. Maybe I cannot be so precise that I do for breast algo, in which I know exactly which implant I'm going to put in. But it's always a question on thinking what will come back in the lower pole expansion, for example. And for sure, I think we must always minimize our breast implant contamination. And I published a sort of remake of the Franz Bill Adams about the 14 points, and I wrote about the 12 breast reconstruction points. So another important concept, I have to thank Alberto Rancati. This is article, I suggest you to read this paper, because I think it's the basement to achieve good breast reconstruction. Because he said a very simple but fundamental concept. It's not a question of volume, but it's question of presence of adipose tissue. So it doesn't matter if your breast is big or small. It depends for reconstruction how much is the subcutaneous tissue, because you can predict which kind of flap are you going to have after mastectomy. So he classified 3 types of breasts. And so this is very important. And moreover, after the preoperative assessment, another game changer in my practice, I use it routinely, is the ICG. What is ICG? It's something that try to assess properly which is the vascularization of your flap, because sorry for people say to me, oh, I'm able to watch it and understand. Yes, maybe it's true, but I think when you do ICG, you have a clear situation of which vessel perform your skin. And this is, I think, very important, especially in type 2 patient, which is the gray zone between 1 stage and 2 stage. So which implant? I was a Macrotexture user, and in 2018, when they removed from the market, at the beginnings, I thought it was a sort of tragedy for my practice, because I was so deeply convinced that they were the best implant ever. And the other fear I had is to become like in the United States, or in Australia or in France, where they are unlucky because they have only smooth round implant. And you see, this is a very famous guy who made a typical breast reconstruction in the United States. And they put the expander, they put the MDM on the front, they put the P4HP in the back, they put fat. So I think this is crazy, especially because in my country, with a healthy system, it could be impossible to spend this amount of money. But thanks God, we are in Europe and we have an incredible armamentarium, and we must use different implants, texture, polyurethane, whatever you prefer, but you must choose. You have a lot of things to choose. If you're interested in, I was always concentrate. This is my paper published on PRS about capsula, because this paper helped maybe you to choose which could be the best surface for your patient in breast reconstruction. And based on evidence, now this is not my personal opinion, polyurethane foam, it's the best surface because it allows you to have low capsular contracture rate, and also to have a precise pocket control, because I don't perform mastectomy. I receive mastectomy from my great oncologic surgeon, and sometimes I have a big pocket. And with polyurethane, this is not a problem, because you have a spontaneous spontaneous skin redraping on your implant, which is very important. And thinking about innovation and try to do excellence for our patient, we have to take into consideration this new kind of implant. It's the ultra lightweight implants. It means that they have borosilicate particles inside, so the total weight of the volume is 1/3 less. And do you imagine thinking about the Hooke's law, which means that much is the heavy and tissue, much is the stress. Imagine how this concept, which is very important in aesthetic breast aug, it's 3 times more important in breast reconstruction because we don't have gland anymore. We have all the weight of the breast is all implant. So imagine how much is important to give a lighter implant to our patient. And when they are very useful, especially in complex case like this. She had a very poor tissue quality, previous weight loss, previous mastopexy, inverted scar, put tissue, smoker, adjuvant therapy were already planned. So in this case, when I put expander into muscular placement because the flap was so thin, there is no choice to do a prepack reconstruction. I leave expander to be radiated because in my practice, this is a typical situation of a capsular retraction. And then I perform a capsulectomy. And then you can use ultra lightweight implants, polyurethane coated. And the nice thing, it's always to see what happened in radiated patient. This is 1 year post-op. So I think these are very pleasant results considering radiation therapy. And what else? When we talk about the 3 types, so as I told you, when you have a skinny patient, you don't have DAPs, so you must choose to stage breast reconstruction because they are not good candidates. You see here they have so thin quality of tissue. In this case, I also perform a capsular flap. So this is necessary to stage breast reconstruction, but this is not a tragedy because this is the right technique for that patient and you can achieve really pleasant result. And for sure, when you have type 2, it means it's something in between, a very good thickness, and you can choose ICG. And this is a 77 years old, and she's so happy because she improved the final aesthetic result. And another things I want to show you, talking about the preoperative planning, you see where I put the inframammary fold incision. I'm very lucky because I can draw my patient and my Synology respect my draw. And the nice thing is that if you put, for example, put your inframammary fold incision in the fold, after you have to calculate the expansion with the implant, you should have the inframammary fold incision in the lower pole, which is something unpleasant. Instead, if you make a calculation, a precise calculation, you can achieve your scar perfect in the new inframammary fold, exactly as we do in breast augmentation. You see the scar is almost invisible because it's under the breast. It's here. It's invisible because it's in the right place. And also when you have asymmetry between the 2 breasts, you can't do the same incision. Otherwise, I should put the fold is here, would be a tragedy because it would be the inframammary incision in the lower pole. So again, you do the right planning, you do the right draw, and then this is the immediate post-op, you see the scar is in the fold again. And another very important concept in pre-pack reconstruction is that we have really low rate of capsular contracture. They need lipofilling. You must know this, and you have to inform your patient. I always, in my informed consent, said that in the 90% of patients, they need to do small lipofilling to do refinements. So this is not a big issue. But let me say one important thing about radiated breasts, because for me is my nightmare, is my real enemy. And I think that something is changing. I didn't understand perfect in the previous speaker, but maybe he told something else about new tool, in radiation therapy. We have a new protocol, which is very interesting. It's the half moon technique, and it's a technique hypofraction as and very nice because they deliver 44 gray instead of 50, and they spare completely the implant. And together with the pre-pack positioning, which is, I think it's the real tool to have a lower rate of capsular contracture, this is our possible scenario that you can achieve. This is a triple negative right breast cancer. She did this is the intraoperative view, but this is not important because this is a good result for sure, but this is before radiation therapy. I'm interested to show you instead what happened after radiation therapy. So you imagine this is something that could happen only with autologous flap when I was a resident. And today we can achieve this result. And this is not the only result that I'm showing to the Congress, but I have many of this kind of results. They are all in pre-pack position. And it's so nice to see over the time. This is at least 2 years post-op. So you see, this is reality. So everything is changed also in radiated patient. And this is my last patient. I just saw her on Friday. I just make a video for you because it was very nice to see. So this is another radiated patient. So this is incredible because they seem augmentation, they don't seem radiated patient. So this is the most incredible things. And the same concept, for sure, you can apply it in revisional cases. I do a lot of revisional cases. And the beautiful thing sometimes when it's possible is to change the plan, to move from retromuscular to pre-pack. This is a lady, and she just changed the plane, changed the implant, of course. But you see how pleasant in the result. This is another kind of breast. Or sometimes when you have a poor plan, because this is a one stage, so this lady maybe should benefit to do a two-stage breast reconstruction. But if you do a good release of the pocket, if you release all the inferior pole, you can achieve pleasant result. Or maybe how much time, how many cases like this we see. This is a typical capsular contractor. There is implant displacement, cranial dislocation, empty lower pole. This is terrible. She didn't want to touch up the contralateral breast. And if you change the plan and you do only one lipofilling, this is the result. You can achieve really a pleasant and good symmetry over the time. And this is another case, just to change of plane. And I have to thank Roy DeVita, who teach me a lot of things about that. It's so true, his famous sentence that if you go in pre-pack, you never go back. So in conclusion, breast reconstruction is not like breast augmentation 100%. However, I'm strongly believe that if you make a very careful patient selection and you plan careful every details of your reconstruction, you can really achieve highest level of beauty also in cancer patient. So thank you very much for your kind attention.
Thank you, Dr. Cagli, for a very nice and detailed presentation. Any questions from the audience? Would you share some pearls as far as animation deformity when you go under the muscle?
Sorry, I didn't understand. Did you ask me?
Right. Do you have any advice on how to handle animation deformity when you go under the muscle?
This is a very nice question. The reality is that it is a normal consequence of submuscular placement. So in some cases, when I see on the table that she has a very, very strong muscle, sometimes I split in two parts. And this is allow me a little bit to make less animation, but it's impossible to make zero animation in this patient, and you have to inform your patient. That's why my preferred choice is 100% pre-pack. But of course, as I tell you, it depends on anatomy condition because it's not always possible to go under the muscle.
And what about radiation? Do you think that it is better to radiate a prepectoral or a retropectoral reconstruction?
Yes, thank you. This is one of my favorite questions regarding. So I'm deeply convinced, and I would like also to share your opinion about that. I understood over the time that the biggest problem we have in radiated patient is the fibrosis of the pectoralis major, more than the skin. I was sure that the skin was the real problem, but I realized that the things that create major distortion is the pectoralis major. That's why I always, when I can see that I have less capsular contracture in pre-pack reconstruction. And this is a proof in my practice because, and for these reasons, I prepare to, when I can do pre-pack and I also know they're going to be radiated, I prefer to leave the implant in because the capsular contracture rate is lower. On the contrary, as I show in the case I showed you before, when I am obliged to do under the muscle, I always leave an expander because I need in the second stage to perform a capsulectomy and to put polyurethane after radiation therapy, because now my belief is that I have to try to remove the capsular already radiated and leave the polyurethane, try to do is capsular, which will be, of course, not a normal capsula because we know that it's a chronic disease, the radiation therapy. But I think I have less capsular contracture with this kind of protocol.
Thank you very much. I appreciate your input. So now I think we're ready to move on with Dr. Gravanis, who's Chief of Plastic Surgery at Metropolitan Hospital, very experienced colleague and friend. Andrea.
Ladies and gentlemen, good afternoon. I would like to thank the organizing committee for the great honor to participate in this panel. Escape. Το πάτησα.
Είναι ανάποδο.
Μήπως να πετύχει end show.
Είναι ανάποδο. Ήταν full screen όταν το συνδέσαμε γι' αυτό.
Okay. Εδώ είναι.
Δίπλα.
Okay. So, this book is my only disclosure related to this talk. As a plastic reconstructive surgeon, when we are facing a breast reconstruction case, we would like to deal with the ideal patient, meaning a patient young, healthy, with a normal body weight, and also with the ideal breast, meaning a breast of small to moderate size with no ptosis. In such patients, we can offer bilateral mastectomies and direct to implant reconstructions, either prepectoral or in the carefully selected patients, subpectoral, with a very good aesthetic outcome and a long-term result. Even in such patients, young and healthy and slim, even with radical mastectomy and radiation, with autologous microsurgical reconstruction, we can offer them a very natural long-term result. Nevertheless, occasionally we have to face difficult patients and difficult breasts. We would define as difficult breast every breast that is ptotic with a ptosis greater than grade 2, ptotic breasts in obese patients, ptotic breasts and asymmetric, obese patients that have a history of radiation therapy. And from the reconstructive point of view, the real enemy for the reconstruction is the history of radiation therapy in whatever stage of the patient, either prepectoral or either preoperatively or postoperatively. It is an official statistic published by the FDA in 2009 that the 70% of implant-based reconstructions associated with radiotherapy at 7 years have failed. Looking at the official statistics of American Society of Plastic Reconstructive Surgeons that they have been published in 2020, over 137,000 cases of breast reconstruction have took place, with the vast majority, over 103,000, to be implant-based reconstructions, indicating that this is the most readily available method for every surgeon and every center, and probably the most attractive option for the woman because it has not been to be operated in another side of her body. There was a significant decrease in 2020 in the use of pedicle musculocutaneous flap, less than 3,000, as indicating the significant morbidity that these flaps are associated with, a significant increase in microvascular reconstructions. Over 31,000 breasts were reconstructed with a free flap, mainly with a DIEP flap. And it's very interesting, the last statistic, where we can see that over 22,600 implants that they have been used for reconstructive purposes, they had to be removed in the same year, almost the 1/5 of the reconstructions for whatever complication or aesthetic reason. So for the majority of the women, the autologous body tissue for the reconstruction does not sound attractive option, either because it's a longer surgery, either it's a more expensive surgery, but there is no doubt that it results in a more natural lifetime result. So now I'm going to go through some clinical scenarios that we are usually facing in our daily routine. First scenario, an obese patient with ptotic breast that she was referred to us for a delayed reconstruction. The patient had no history of radiation, but she had a history of implant infection, extrusion, and finally explantation. The question of the patient was, can an implant offer a reasonable reconstruction to her? And our answer was no, because a patient with this body status, an implant cannot recreate the footprint of the breast, the skin envelope, and the conus. So we proceeded with autologous microsurgical reconstruction. Scenario number 2, obese patient with a ptotic breast that was referred to Dr. Venizelos and our breast unit, that she presented with a carcinoma on her right breast. Her BMI was over 37. At the biopsy revealed ductal carcinoma grade 2. She had already a positive lymph node, so she was a candidate for post-mastectomy radiation therapy. So the patient was young, less than 38 years old, and she requested an aesthetic outcome. She had two options, either to proceed with mastectomy and temporal placement of a tissue expander, or to proceed with oncoplastic surgery. So we decided to go ahead with superomedial pedicle technique to uplift the breast, reduce the size, and also remove the tumor. So we had to use ICG to verify the tissue viability and the nipple areola complex viability, because of the very low position of the nipple was about 42 centimeters, the distance of the sternal nodes to the nipple. Frozen sections were used to verify the tumor resection. So this is the early result of the patient. She had an uneventful healing within 3 weeks, so the patient was ready for post-mastectomy radiation therapy very soon after her surgical treatment. Scenario number 3, patient with heavy ptotic breast, also a patient that was referred to our breast unit with a tumor at her right breast. This is the volumetric analysis of the patient. The patient had a negative sentinel node preoperatively, so she was candidate either for lumpectomy and post-mastectomy and post-operative radiation therapy, or for mastectomy and direct to implant reconstruction. But we explained to her that with this heavy breast, with this large skin envelope and the low position of the nipple, possibly the result of the direct to implant reconstruction would be with a poor outcome. So we decided to go ahead with a 2-staged operation. Given the location of the tumor, we designed a superomedial pedicle oncoplastic surgery to uplift the breast, remove the tumor with safe oncologic margins. And actually the procedure is a prefabrication for a nipple areola sparing mastectomy at the second stage. So this is the first surgical stage of the patient. So we see the result on the right side. We reduced the volume from 1,100 cc to 550 cc. The tumor was already removed, and we uplifted the nipples in the right position. So practically we transformed the patient from a poor candidate to an ideal candidate for a subcutaneous mastectomy that was performed 1 month later, and direct to implant reconstruction that was performed prepectoral with the use of a mesh braction and a lightweight implant. This procedure is actually well known in the social media among the patients as the Angelina Jolie procedure, because the famous actress popularized the method in the social media. Practically, the patient had 3 operations. At the first stage, she had a breast uplift. At the second stage, subcutaneous mastectomies and temporal placement of a tissue expander. And at the third stage, reconstruction with the exchange of the tissue expander with a permanent implant And actually, the third stage can be skipped nowadays with the modern biological meshes or with the microthin implants. We can have direct-to-implant reconstruction with very good cosmetic outcome. Scenario number 4. A patient that was referred to us, she already had implant-based reconstruction, she had radiation, presented to us with a very hard breast, capsular contracture, grade 4. She developed a painful capsa. She reported the feeling of the cold breast, and she wanted to get rid of that, and the only way to create a new skin envelope is to transfer to her a soft, pliable flap. So she had a DF flap, and at the same stage, uplift of the contralateral healthy breast. Scenario number 5, implant-based reconstruction and radiation, a really complex breast patient. She was obese, she was a heavy smoker, she had radiation in the past on the left side, she had 8 previous reconstruction for the 8 previous operations for the breast reconstruction only. She suffered from exposure infection of the implant on the left side, and she developed capsular contraction grade 4 on the right side. She had also a history of pulmonary embolism during the course of chemotherapy, so I think it's the definition of the complex patient and the complex breast reconstruction case. But looking at the vascular anatomy of the patient, she had very good perforator anatomy at the abdomen, so we proceeded with one stage microsurgical breast reconstruction with DIEP flap, and the patient got it a lifetime soft natural result and significant improvement of her body status, considering also the abdominoplasty. Scenario number 6, also a patient from our breast unit. The patient presented with asymmetry and radiation. The patient had previous lumpectomy and radiation. Now she presented, I think, with a new cancer. So the plan was for a mastectomy with a removal of the nipple areola complex. She was a poor candidate for implant-based reconstruction, given the fact that she was previously irradiated. Also, she requested for reduction at the contralateral side for symmetrization. So we proceeded with one-stage operation, mastectomy, reconstruction, and symmetrization in a single stage. The last 5 years, we have developed in our unit a 3D medical imaging and printing lab consisted from a photoscanner, a Vectra XT by Canfield, a portable photoscanner as well for intraoperative use, and 5 different printers. So with the use of the commercial scanner, we create a 3D image of patient chest. We can perform a simulation of mastopexy, reduction, or augmentation of the contralateral breast where it is necessary. So then we print the mirror image of this model. We have developed our own software to extract the images from the photoscanner and transfer them to the 3D printer and get all the pertinent models, rapid prototyping models of the mastectomized chest, healthy breast mirror image, and the abdominal flap. These models are sterilized and used intraoperatively as sizers. Regarding the abdominal flap model, we use the images from the patient's abdominal CT angiography that we always use preoperatively to identify the dominant perforator, and we use this model to shape the flap. Then the flap is placed inside the printed template of the breast to verify the shape and the volume, to aid the surgeon in determining the shape and volume of the autologous flap, creating the desired breast dimensions. First example, a slim patient with a healthy breast, moderate size in normal position. Probably this is the ideal scenario to give symmetry in one stage to the patient with a microsurgical free flap. More challenging scenario, a patient that she had nipple-sparing mastectomy, the temporal placement of a tissue expander. Initially, the patient had an ideal shape of this breast with very good proptosis, but gradually, with the progress of time, after 9 months, she proceeded with this appearance severely contracted of the lower pole of the breast. So the other breast was ptotic. We generated the image of the breast uplift and slight reduction. We printed these models, so we achieved in one stage this result to the patient, microsurgical breast reconstruction and contralateral breast uplift. With the use of these scanners, we can calculate postoperatively the volume difference between the two breasts, and we constantly find not significant difference among the two breasts. Another case of a patient with radical mastectomy, radiation, and a quite big breast on the contralateral side. With this technology, we offered in one stage reconstruction and symmetrization. Even more challenging case, patient who had bilateral mastectomies. She had previous radiation on the right side, so she suffered from skin necrosis, implant extrusion, and finally necrosis. She proceeded to us with this appearance, this patient volumetric analysis. We have used also this method. We printed all the pertinent models, used them intraoperatively. So we did on the one side the microsurgical breast reconstruction, and on the left side we did exchange of the implant to a smaller lightweight B-Light implant at the same stage, and the volumetric analysis showed very small difference among the two breasts. And as a final example, this patient had a tissue expander on the right side and a small to moderate size on the contralateral side. So at the same stage, we did microsurgical breast reconstruction and augmentation, and actually it's very difficult to differentiate here from a non-mastectomized woman. I think that is about time to change how we think about difficult patients, about difficult reconstruction cases, and I think it's more reasonable to think more two-staged, enlarged ptotic asymmetric breast, given that this is oncologic safe. So to do at the first stage lumpectomy and reduction, transform the patient from a poor candidate to an ideal candidate for a second stage to proceed with risk-reducing mastectomy, subcutaneous mastectomy, and prepectoral reconstruction. Think more autologous definitely in irradiated patients. Think more autologous in overweighted patients, and also for the future, I think 3D technology as a useful aesthetic tool for optimizing symmetry. Thank you very much.
Thank you, Dre, for a very nice presentation of some very difficult cases. Any questions? Well, you gave us some very nice applications of Dr. Spear's work of staging a breast reduction as well as lumpectomy in cases of overweight, big-breasted women. Dr. Kagli, you have a question?
Yes. I will ask you, because in my practice, I use very less time the direct implant in a skin-reducing mastectomy, but I totally agree that they're very difficult case, but to put an expander doing a breast skin-reducing mastectomy, do you think is not useful in the same way? Because in the second stage, I can do all the other definements of the technique. I mean, it's 3 surgery compared to 2. I think it's very difficult to push to make a so complex plane to my patient. So that's why I do skin reducing still with expander instead of implant, but not 3-stage.
No, actually we do also 2 stages. At the first stage we do the breast uplift and the removal of the tumor, and at the second stage we perform the subcutaneous mastectomy and the direct implant reconstruction. So it is also 2-stage operation.
Okay.
So because it depends on, I think in your experience, each surgeon's experience, but If you do at the first stage just a mastectomy and the placement of a tissue expander in a large skin envelope, still you get risks from the perfusion of the skin flap. And at the second stage, it's not always easy to uplift the breast with the simultaneous placement of the implant.
If I may, the point of the procedure is to assure the vitality of the nipple areolar complex once the surgery is over. Not so much to reduce the breast as much as allow for the delay phenomenon on the nipple areola, so that, and this is actually what Jolie had, so that you end up with a better perfused nipple areolar complex. Any other questions? Thank you very much, Andrea. And now it's our pleasure to welcome Dr. Antonopoulos, who is also a very experienced plastic surgeon and friend, and who is currently the director of plastic surgery at Olympion in Patra, as well as a collaborator at Metropolitan Hospital. Dimitri.
Χαίρετε σε όλους. Ευχαριστώ την Οργανωτική Επιτροπή για την πρόσκληση και ειδικά το φίλο μου τον κύριο Βενιζέλο. Αυτό δουλεύει με το Enter, Έχει συνδεθεί τώρα αυτό? Όχι, θα βάλω αυτό. Μ' αρέσει αυτή η φωτογραφία. Έτσι θα αρχίσω. Ναι. Λοιπόν, okay, thank you very much. Thank you very much. I'm Dr. Antonopoulos. I'm going to expose my experience, 60 years, more than 6 year experience in using the polyurethane implants. In my practice, I moved. I work on all the techniques, even microsurgery, in breast reconstruction, and I start using meshes in subpectoral position, and then sometimes a few ADMs. And finally, in 2017, I had the idea and the question in my mind, no disclosure, that it must be something, one device that has everything. That means be stable, be safe, and give a natural results in a long-term following up, and low cost. Working on the private sector, I think the cost and the complications, all the things are a disaster for us. So, and second, I thought what the woman needs. And finally, I did this slide here. The patient needs a security, fast recovery, to be comfortable, have a good natural results, less pain, less surgical steps. All these queries, we have to concern that first thing we have to do is the patient selection. And that's the key of the good result. And the patient selection must be discussed with breast surgeons and do the plan. So why the microurethane implants? Because it's the less surgical time, it's the pressure on the vessel supply of the remaining subdermal envelope is less. We avoid any other use of ADMs or meshes. That means less cost. In subpectoral or dual plane position, I can show you my technique on avoiding animation deformity. And the most important is that it's the less capsular contracture in the long-term follow-up. But in the meantime, in my experience, using this technique and the microurethane implants, I've never seen any serious seroma. So the drains remain just for 5-6 days. This is a specimen, pathologically a specimen showing the thickness total thickness of the polyurethane, the thickness of the capsule is 0.2 centimeters, and the polyurethane thickness is 0.2. So how the microthane works? It works, the polyurethane is a scaffold where allows the new tissue to grow into, and then that's why it produces a very thin capsule. But the most important is that after 6 months, the internal silicone, which is a true silicone implant, separates from that capsule and moves more easily and more natural into the breast. So this is a picture showing the thin capsule produced by the microthane implants. The most important in the direct-to-implant breast reconstruction, according to my experience, is the preoperative planning and preoperative measurement, and which must be discussed by the breast surgeon in details. And then, according to these measurements, we have to choose the appropriate implant to put in. And we can see how the blood supply remains. It's very important to keep an eye on the second and third perforator intramammary vessels to avoid any problems with the blood supply of the remaining envelope after the mastectomy. So some tips and tricks in preoperative or during the operation is as Dr. Gagli said before, is we can evaluate the according to the Racanti classification, the type of the mastectomy and the type of the type of the placement of the implant. So in this is the fatty breast, so we have to keep during the mastectomy a big, more than 1 centimeter thickness of the flap, and in that case we consider to go in prepectoral position. But here you can see that the remaining fat in the envelope is just the skin. So in that case, I think we must think other solutions and other position of the implant. Another tool is the using of ICG, the ICG camera in the during the operation after the mastectomy. I prefer to put the sizer in and keeping the patient in the sitting position, so all the gravity of the implant we can see, we can evaluate then the vascularization of the remaining of the overlaying tissue. Dual plane technique, partially covered by the pec major. Now we can, my technique is to avoid the breast animation, is to do a selective denervation of the pec major nerves, which, as I show you, works very well. I used this technique more than 5 years, and I have a long-term, very long-term follow-up. And you can see here the remaining fat of the envelope, which is about 1 centimeter, which show us a very nice mastectomy with a very nice place to put the implants in prepectoral position that we did. So a long discussion about the prepectoral or subpectoral position of the placement of the implant. And these discussions influence the patient. I had a patient a couple of weeks ago, and she told me, "Okay, I want the implants to be placed on the prepectoral position." And I answered to her, "No, this is my choice, my personal choice, which I'm going to do it during the operation. So, according to me, doesn't matter if it's prepectoral, if subpectoral, which is the surgeon decision-making in the operating theater. Of course, the prepectoral position is better, is more quick, more easy for the patient, but I think the final result is that which interests the patient, and the final result which lasts. So I think it's our decision. Here I show some cases through my experiences, bilateral mastectomy. Here with right breast cancer, prepectoral position of the microthin Belite implants. 3 years later, another case on the right side, cancer of the breast, I think was BRCA positive. So we did, the breast surgeons team did a bilateral mastectomy. You can see here the difference of the nipples. It's a slightly asymmetry. And here is 4 years post-op. Where we can see this video, how the implants remain almost in the same position where they were put before 4 years ago. Another case, there are two relatives. This young lady had BRCA positive and her aunt BRCA positive. We operated 4 years before the aunt, and now this young lady underwent the bilateral mastectomy in prepectoral position Belite implants, polyurethane Belite implants. But I can show you this. This looks very, 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 I think, not good result from the beginning. Something happens. The breast is hanging a little bit, but we can see how the microthin implants transform during the years in this, okay, which is very, very good, a very nice result. And actually, in this case, I use big implants, more than 550 cc. Another interesting case, this lady had the breast cancer on the left side. No, had, sorry, yeah, she had a lumpectomy and radiated the right side of the breast. And then from some reason, oncological reasons or a recurrence or a new, I don't remember, she had removal of mastectomy of the right side, the radiated breast, and prophylactic mastectomy on the other side. So what we did, backspace, so what we did is to put the implant here on the right side, behind the pec major, using the selective denervation technique, and on the left side, in prepectoral position. And after that, we can see, sorry. So, and after that, we can see the result, which is almost the same. And you can notice that here in the retromuscular position with denervation of the muscle, comparing with the prepectoral position of the implant, there is no animation. It's almost the same, no movement of the muscle. Bigger breasts, large breasts, one stage, direct to implant, using big implants, Belite, in prepectoral position, a little bit of lipofilling in the meantime, after 4 years. Another case, big implants, bilateral mastectomy, cancer on one side, prophylactic on the other side. Belite microthin implants in prepectoral position. You can see after, no, it's 4 years actually. I presented this video in the last Congress. That last year was 3 years, now it's 4 years. So you can see how soft is the breast, nice movement, a nice natural result. The same large breasts, bilateral mastectomy, skin sparing, but not nipple sparing. We use a depithelialized lower flap in the Weitz pattern technique, and then I put the implant behind the muscle partially, and then I use the lower part of the depithelialized skin flap as a support, and this is the later result after 3-4 years again. So what we do in the direct to implant technique, I agree with Andreas that the best thing is to do breast lift first and then reoperate and put the implants. This is actually, I agree completely that this is the best result. But some cases, some patients, if you speak to them that they're going to have 2 operations, they are beginning to be skeptical. Second, my question to address is because those patients are oncological cases, so they have to start with chemotherapy, maybe with other treatments. So I think if we can do and to achieve a good result, I would go for direct to implant in one operation, so the patient is happy. But we have to move to do the lift of the nipples. That what I do is this double bat wing technique, which keeps all the areola vascularization intact. Put the microthon in prepectoral position, and this is the result in postoperative after 1 to 3 months. A lady, 70 years old, bilateral mastectomy, and what this lady wants and what needs a quick operation, okay, an average result, but a quick recovery. What we did, this operation lasted about 3 hours and a half, bilateral mastectomy, prepectoral position of the implant, no problems, no complication, not the best result, but the same as it was before. So the patient is very happy. She lives in Crete, and after 10 days she moved to Crete. Post-op radiation. I agree with Dr. Gagli that in prepectoral position the radiation affects less the result than the retromuscular position of the implant. In this case, this lady, this is the preoperative picture, and this is 3 years after having radiated the right breast. Another case with preoperative radiation. This young lady having done before lumpectomy and radiation of the right breast, and then we proceed in bilateral mastectomy. This is the picture after 2 years post-op, and this is 2 years post-op. And here is 5 years post-op. Actually, this photograph is 1 week ago when we met here again. She came from Rhodes in the breast unit. More complicated cases. This lady had a lumpectomy, had radiotherapy, reconstruction using implants. You can see the disaster. So what we did here, we did a transposition flap off from the abdomen using a tension sutures, as you can see here. All the way down, this flap is moved up. Capsulectomy, removal of the implants, and put the new implants in prepectoral position. And this lady is not the excellent result, but she's very happy because almost the breast is very soft and she's very happy actually. So some problems, there are complications, but the problem is to avoid the major complications. So in my experience, I show you some things, some small things. We can see after a week something happens around the areola. We have to wait. The benefit of using of microthin implants is the surrounding tissue is adherent, as in κολλημένο. Yes, on the skin. So any problems remain just in this area here. So you can see waiting how becomes without any major problems. Red breast syndrome, I've seen it in 3 cases. Just wait, giving some corticoid and rippling. Yeah, okay, I agree, rippling. Okay, but you see the result in direct to implant, lift, bilateral mastectomy, okay, there is a rippling. What we do? Some lipofilling. Sometimes I use lipofilling intraoperatively as well. Loss of implant, this is a nightmare. This is a nightmare. When you put the implant in prepectoral position, is no way back if something goes wrong. In these cases, which is a doctor actually, she had a bilateral mastectomy, prepectoral position of the implant, and then infection, remove the implant, and put the new expander, and then second operation, remove the expander, change with permanent implant, and you can see how the scar removing of the implant was up here. All this is producing by expander and using the flap of the abdomen that I showed you before with the tension sutures. Yes, another case with radiation. This is the breast radiated postoperatively. A few data now. I mean, the last 6 years, 185 cases, 308 implants. Okay, but we use a minor reoperation for like lipofilling in 30% of the cases, a revision of the implant in 4 cases, and some scar revision in 3 cases. We prefer, as a team, the inframammary approach for the mastectomy. And then the patient satisfaction in the bilateral is very high, and I agree with that. But the difficult cases are the unilateral. So concerning now the complication rate is very low. It's 8%. We lost just 2 implants because of infection, and we have some problems around the areola, and in cases where we have 7 cases of post-operative radiotherapy, which from the 7, the 3 they produced in the Baker 3-4 capsular contracture, and the implant was in the retromuscular position. As a conclusion, I think we have to keep this, that the good mastectomy requires the good anatomical and ecological mastectomy, the good reconstruction. This is the key of the good result. And then you can see all the other details. So there are many ways to arrive in the destination, our destination is the oncological safety of the patient and the patient satisfaction having the result. There are different ways, different things, but the most important is the collaboration, the breast surgeon with the experienced plastic surgeons. This inquiry, who is the blame? Who is the blame? Is the surgeon? Is the patient? Is this? What happened? This is a disaster. It's a completely disaster. According to me, the plan was very wrong from the beginning. Our team here, okay, I thank you. And this is my email for any contact on any discussion. Thank you very much. Ευχαριστώ.
Thank you very much, Dimitri, for an extensive use of lightweight and polyurethane implants. Any questions, please? Would you clarify for us? Dr. Maragoudakis, please.
Thank you, Dr. Esa Barbara Galli, for your talk, and thank you all for your talk. I would like to ask you if you're taking in account the preference of the radiation oncologist concerning the prepectoral or subpectoral application of the implant. And I ask that because if you apply the half-moon technique as shown by Dr. Esa Galli, and in this case, we are not irradiating the pectoralis muscle. And this is very good from the aesthetic point of view, but it's not all the time good for the oncologic point of view, because if the tumor is located close to the pectoralis muscle, and if the muscle is unirradiated, in this case, we have an increased incidence of recurrence. So I think that we have to talk about what's the preference concerning the radiation oncologist.
Okay, thank you for the question. Of course, the decision is based always on oncologic features of the patient. So I show you the protocol in case you don't have a difficult situation. I mean, our radiation, they think first about the oncologic way and then about the aesthetic results. So my presentation was just to show you that we are following, when it's possible from an oncological view, the half-moon technique, but this is not the routine for all the patients. So they make, always radiation therapy is customized on patient oncological features.
Can I?
Thank you, Dr. Kagli. Any other questions?
Can I add something? Yeah.
Please.
In breast unit, working on the private sector, I'm not so happy if preoperatively we know that the patient is going to be radiated after the mastectomy. In that way, I prefer to put an expander. And I prefer to put an expander in the prepectoral position if the thickness of the skin and the fat allows me to that, and then do, two stages procedure, because it's. And another thing is who is doing the radiation. I think it's something you can't measure this. Like the surgery, who is doing the surgery? I think these variations there are in everyday practice. But imagine that something goes wrong with radiation, having put the implant in, you have to go back and proceed the second operation, which must be autologous tissue transfer using DF. So I think this is our protocol.
I'm afraid we're running out of time, so we'll please ask for the rest of the questions and discussion to follow up later. Το διάλειμμα τώρα περιλαμβάνει το φαγητό, το οποίο είναι στον 7ο όροφο και θα έχει διάρκεια μισή ώρα. Ευχαριστώ πολύ.